Good evening, and welcome to Doctors on Call. I'm Dr. Peter Nalin, Professor and Head of the Department of Family Medicine and Biobehavioral Health, and Associate Dean for Rural Medicine at the University of Minnesota Medical School, Duluth campus. I'm your host for our program tonight on men's health, prostate, bladder, and kidney problems. The success of this program is very dependent on you, the viewer, so please call in your questions or email them to ask@pbsnorth.org. The telephone numbers can be found at the bottom of your screen. Our panelists this evening include Dr. Benjamin Marsh, a urologist with Essentia Health, and Dr. John Wood, a family medicine physician with Essentia Health and faculty member at the Duluth Family Medicine Residency Program. Our medical students answering the phones tonight are Riley Berg from Bemidji, Minnesota, Micah Christensen of Alexandria, Minnesota, and Alex Host from Brainerd, Minnesota. And now on to tonight's program on men's health, prostate, bladder, and kidney problems. And Dr. Marsh, the first question this evening is, would you briefly explain the difference between bloody urine and microscopic hematuria?
Sure, Peter. So bloody urine, I guess we would be calling that gross hematuria in the medical word, and that just means that you can see the blood in the urine with your naked eye. Microscopic hematuria means to you it looks pure yellow, but under the microscope they might see a few red blood cells. And so those aren't supposed to be there. That's abnormal. We call it microscopic hematuria.
Thank you. Dr. Wood, please name or explain a reason for needing to get up at night to urinate.
Well, that's a big question. That's a broad topic. The technical medical term for that would be nocturia. And nocturia can be a sign of basically a storage problem with your bladder, meaning you're not able to store enough urine, so you can't make it through the night. So often you'll have to go to the bathroom multiple times during the evening. It could also be a sign of an infection. So nocturia could be a sign of maybe your prostate is enlarged. You think of a term called BPH, which is actually a fairly common thing as men get older. But not all men develop symptoms of nocturia, but most men have an enlarged prostate. So that's not an unusual thing in and of itself. But nocturia could be a sign of kind of a chronic problem. Perhaps you've got an enlarged prostate, you're not able to store urine, there's a lot going on when you have BPH and LUTs or lower urinary tract symptoms. There's a lot of pathology there, but often the symptom would be you get up at night to pee. Another sign could be that you might have an infection and you need some more acute management. Perhaps you need an antibiotic. Another sign could be perhaps your medications need to be adjusted. You're on medications. If you're on a diuretic, for instance, in heart failure, you're going to have to get up to urinate. Perhaps you could talk to your physician or provider, because there's a way to dose those where you might not have to urinate at night. Another sign could be that you could have a chronic medical problem that's manifesting itself as nocturia. There's lots of things that could cause too. Parkinson's disease, for example, or whatever. Some problems can present in all different kinds of ways. So I hope I covered that.
Yeah, you sure did. Dr. Marsh, what is chronic inflammation of the bladder and how is it diagnosed?
So I think what you're referring to would be, the term we might use would be interstitial cystitis. Another name for it is chronic bladder pain syndrome. And this is a condition that's not extremely well known how or why it develops, but it basically manifests as pain, specifically with a full bladder, and also associated with frequent and urgent urination. You asked how it was diagnosed. Typically it can be a diagnosis of exclusion, so making sure there's no other possible explanation for that. And then often we'll also do what's called a cystoscopy, which basically just means taking a small camera and looking inside the bladder to look for signs of inflammation.
And following up on that, looking inside the bladder, could you just tell us a little about what procedures are available for visualizing the bladder?
Yeah, so probably the best procedure is a cystoscopy. So basically this is a procedure that's commonly done in the clinic with patients awake. And usually when I say that, people's eyes roll back in their head, but it's usually not as bad as you might think. We put some numbing jelly in the urethra and take a small camera, take a look inside. Takes about 45 to 60 seconds. It's pretty quick. That's definitely the best way to get a look inside. Sometimes we'll use some imaging tests like a CAT scan, but generally the best thing would be direct visualization.
Thank you. And Dr. Wood, we've heard of kidney stones, but what are bladder stones?
Well, bladder stones are stones that would be formed in the bladder, and typically that's from, I think, basically a manifestation of urine that's concentrated, meaning you're probably not getting the urine flow through the bladder, and so stones are going to form inside the bladder, just kind of a low flow state, I think, for lack of a better word. And often, but sometimes, and bladder stones usually manifest because of some other problem in the bladder. Let's say you have a lot of diverticular ridges in the bladder, or maybe you have a mass in the bladder, things that might impede the flow or actually cause. If you think of the bladder as kind of a relatively smooth, or but if there's rough edges, you can maybe get some precipitation of stones forming. And that's when I should mention that often when we're suspecting this, we'll be referring these patients to our urology colleagues, because they'll be the ones that would actually diagnose and probably really work up the cause for that stone, because you need to get the stone to figure out what kind of stone it is.
Thank you. Dr. Marsh, what does it mean to treat a kidney stone with a basket?
Yeah, so there's a number of different ways you can treat a kidney stone. Probably the most common way I do it is taking a small camera and driving up to the ureter or the kidney where the stones tend to be stuck, and using a small laser to break the stone up into little pieces. Sometimes you can turn it into basically dust or fine sand that will just pass out on its own. But sometimes you have bigger fragments left behind, and so we'll use a small basket that goes through our camera so we can grab the stone and pull it out of the body. Sometimes you can get the stone out in one piece without having to break it up, but usually we use a laser to break it up first.
Thank you. That's so interesting. Dr. Wood, what is the term UTI?
Urinary tract infection.
And
Which
what is that?
Well, it's typically, there's different kinds of organisms in the body, you could think, but typically it's formed by gram-negative bacteria, which are often found in the colon, and they can find their way into the bladder by a variety of different mechanisms. And where bacteria shouldn't be, they tend to grow, and when they tend to grow, they tend to proliferate and cause symptoms. And the symptoms could be, you could get very sick, you can have something called urosepsis, where you get actually an infection in your bloodstream that's from the bladder or the kidneys. And often kidney stones can precipitate a bladder infection. Prostate infections can sometimes lead to bladder infections. Infections in the testes can sometimes be manifested as bladder infections. But UTI, and it's relatively simple to diagnose and often relatively straightforward to treat. Sometimes it can be more complex, but it's often relatively straightforward to treat with antibiotics.
Dr. Marsh, what are the top 3 oral antibiotics used to treat, or that you use to treat, bladder infections?
Sure. The ones that I use most commonly would be ciprofloxacin, Bactrim is another one, and then Macrobid are the 3 most common ones I use. We'll leave it at that, I guess.
Okay.
I was going to say the same thing.
Same thing?
So that's good.
Good choice.
Yeah.
All right. Dr. Wood, other than clear or yellow, what might be different colors of urine and what might cause them?
Well, Dr. Marsh already discussed bloody urine, or grossly bloody urine, which of course would get everyone's attention. I'd say urine that's kind of dark brown sometimes can be a sign of a glomerulonephritis or inflammation of the kidney that's more diagnosed with a urinalysis and then probably referred to nephrology to kind of look for the causes of that. So a urine that's more kind of on the tanner or dark brownish color would be something that would be very concerning. Sometimes that can just mean that you're not drinking enough water, but often it can be a sign of something more nefarious. I could imagine you could probably have urine that would be, you could have discharge, maybe pus, for example, that might show, and of course that could be a sign of an infection or a sexually transmitted illness, which of course you might not notice, but you might see some discharge, and then it might discolor your urine as well. But typically urine is going to be clear, and if you see sludge in the urine, like Dr. Marsh talked about, it could be a sign that you passed a stone or something else and this is just a plug for making sure that if you are concerned about something you might have passed in the urine, or if you've got a kidney stone, it's nice to be able to potentially bring that in so that can be examined in the lab. It sometimes helps with diagnosis.
Thank you. Dr. Marsh, why might some doctors be reluctant to do PSA testing? This is from a viewer in ESCO.
Yeah, this can be kind of a controversial topic. There was some studies not too long ago that showed that, or suggested that screening for prostate cancer with PSA testing was not doing much help and was actually harming some people. And so there was a recommendation, I think it was back in 2012.
Yeah.
The US PSTF
yeah.
guidelines that actually recommended to stop checking PSA testing. That has subsequently reversed, and so the recommendation currently is that you should do shared decision making about the PSA screening. But I think that was kind of the start of some primary care providers being reluctant to order PSA testing. And I can get into that a little bit more too if we have time, but maybe we could do other questions first.
Okay. Dr. Wood, a caller wants to know, are there any particular dietary practices that can reduce the risk of prostate cancer? The caller has heard that perhaps tomatoes can be beneficial.
I wish it was that, I don't want to use the word simple because that implies that's trivial, but no. I'd say the best maybe things you could do for overall prostate health would be like things you could do for overall health to begin with. And generally we think of trying to minimize cancer risk in anything is not smoking, exercise, watching your weight, kind of trying to decrease any of these inflammatory conditions that are going to put oxidative stress on your organs. So I would say maybe look at it not so much from a dietary point of view, but also more from a health, more of a global health style approach, if that helps.
Thank you. Dr. Marsh, a patient caller from Duluth wants to know, what is the overall care for medullary sponge kidney, and do you see it, and how common might it be?
Yeah, we see it from time to time. I think this is a condition that urologists and nephrologists kind of overlap. We both treat this condition. A urologist might see this because these patients tend to develop nephrocalcinosis, so they get all these tiny little stones that fill up the kidney. And sometimes those can cause obstruction or pain and require treatment. I think that was, is that what they were asking?
I think so, yes. Let's look. What's the overall care?
Yeah.
And how common might it be?
Sure, I'm not sure about how common it is, but we see it from time to time. And again, from my perspective, it's managing risks of kidney stone and trying to decrease the risk of kidney stone formation for those patients, which can be challenging.
Thank you. I think we covered this about what treatments might be for kidney stones that are stuck in place. Anything else to say about that, Dr. Marsh?
Well, it often depends on the size of the stone and how comfortable the patient is. But generally our first line is trying to let the patient pass it on their own. If the stone is less than 10 millimeters in size and they're not in severe pain or throwing up, we'll often let them try to pass it for a few weeks. If the stone is too large or their pain is not well controlled or there's concern for infection, then we'd be considering a ureteroscopic treatment, so using a camera and a laser like we were talking about before.
Thank you. Dr. Wood, if the two kidneys are usually side by side or right and left, where else might one of the kidneys be otherwise? Are they always
Well, you
up
can
and
have a
high?
horseshoe kidney, which is kind of one big kidney sort of wrapped around, Those are really the ways that or you can have an atrophic or absent kidney on one side and just have one kidney. That's not super uncommon. I mean, it's uncommon, but it's not unheard of. But I would say typically the body's amazing. They sit retroperitoneal, they sit way, kidneys are incredibly well protected, one on each side. And if you have a horseshoe kidney, you might have one kidney, which is what was formed, and that can be in a variety of places, and sometimes one side of the kidney would be a little larger than the other, or you could have an atrophic kidney, one kidney being smaller than the other, or only have one kidney. I don't know if I answered that question, but that's how I would look
The
at
other
it.
place that we might see it, a kidney, would be a pelvic kidney. So when they're forming, they typically migrate from down in the pelvis up to the back, like you were saying. Sometimes, for whatever reason, one might not make it all the way up there and stay down in the pelvis. That would be the other place we see it sometimes.
Dr. Marsh, could you tell us about the educational training after college that leads to being a urologist?
Sure. So the pathway is after college, you go to medical school, like every doctor, and then residency that's specific to urology. Most programs are an additional 5 years after medical school for a urology residency. And then there are some additional training programs you can do with fellowships that are 1 or 2 years after that. But that's the general pathway.
Thank you. Dr. Wood, an 82-year-old male on saw palmetto, and milk thistle, and been struggling with 3 to 4 episodes of Nocturia at night. Are there other recommendations for this caller?
There are medications. This person is taking saw palmetto and milk thistle, and saw palmetto was really popular back in the day, so to speak, but it's sort of lost some of its. Studies have shown that it's not quite as effective as maybe I think everyone would hope. There's 3 different classes of medications you can take. There's alpha blockers, which can work really pretty fast. That can help lower your blood pressure. The problem with those, they cause low blood pressure. There's something called floppy iris syndrome that you can get if you're taking them, and then you go get cataracts fixed, and then you could have a problem getting your cataract repaired. And then there's 5 alpha blockers that block the conversion of testosterone to dihydrotestosterone in the testes that can help shrink the size of the prostate. And then the thing with those is that those can take months to work, but the first one's going to work a lot quicker. And then you can have the phosphodiesterase inhibitors like Cialis, as it's popularly known, that you can also take for individuals that have BPH, can take that medication as well. And if those things aren't effective, then there's obviously surgical interventions that can be done, because I'm assuming we're talking with a gentleman with Nocturia. It sounds like it's been long-standing. That would be referral to urology either sooner or later to discuss more intraoperative or procedural repairs to fix these symptoms, because they can be really troubling. I'm assuming this gentleman isn't on diuretics and all these other things we talked about. So
Pardon me. Yes, thank you, Dr. Wood. Dr. Marsh, circling back to the PSA, are there prospects for a better blood test than the PSA?
Maybe. People have been trying. We mentioned earlier that there's some controversy with it. And part of that is related because the PSA is not a great test. There's a lot of different reasons why it might be elevated that are not necessarily cancer related, such as just having an enlarged prostate, having an infection, not emptying your bladder well. All these things can cause your PSA to go up that aren't related to prostate cancer. But as of today, it still remains the best thing we've got. There are a few new urine tests that people are studying to look for, to try to replace PSA, but they have not managed to dethrone it yet. I would say the biggest advance in this setting that we've made over the last 5 to 10 years has been using prostate MRIs. So it used to be that anyone that came in with an elevated PSA often ended up just getting a prostate biopsy. And there could be some side effects and problems associated with prostate biopsies. And so nowadays, we'll often get an MRI first as the next step after getting an elevated PSA to see if there are any suspicious lesions in the prostate that could be biopsied. And if it comes back totally normal, we might be able to avoid a biopsy altogether. So I would say that's the kind of the biggest advancement we've had in that setting.
Thank you. Dr. Wood, a caller from Clay has started on Eliquis for 6 months with dark brown pungent urine, switched to Xarelto for 4 years, improved to light brown. Is the blood thinner what's causing this?
Hard to answer. Hopefully this individual's had a urine test to look for, we'd be looking for microscopic hematuria. And if that's the case, then I would suggest that if there is blood in the urine, without knowing more details, probably would need to talk to urology, because usually you're on Eliquis or Xarelto for a reason. It's hard to stop those blood thinners. But if you're losing blood in your urine potentially because of the blood thinner, that should be evaluated.
So it could be contributing, but not the whole situation, is what you're
But it's hard to say
emphasizing.
what's really going on without getting a urine analysis and making sure there is blood in there,
Okay.
if that helps.
Thank you for that. Dr. Marsh, what might be the role of catheterization as an option for dealing with frequent urination at night?
I would say that's a pretty underutilized treatment method. Mostly because people don't want to put a catheter in themselves, but also because there can be an increased risk of infection if you have an indwelling catheter in every night going in and out of the bladder. So typically I would say our goal is to try to figure out the cause of the frequent urination and fix it rather than putting a Band-Aid on it, like putting a catheter in every night.
Thank you. Another question for you, Dr. Marsh. Caller was diagnosed with Hydraseal 2 years ago, continues to have no change in size, and is pain-free. Is surgery a must?
So a Hydraseal is basically a fluid collection around the testicle. So basically presents as a swollen scrotum. Generally does not cause pain, but can be uncomfortable just from the size of it. And oftentimes will not go away like this caller is describing. And yeah, generally the best treatment option would be surgery. But the decision to go forward with that is really based on how bothersome it is. So if it's not to a large enough size that it's causing significant discomfort, definitely do not have to do surgery.
Thank you. And Dr. Wood, this caller wants to know what lifestyle modifications like exercise or diet are beneficial for overall genitourinary health and erectile dysfunction.
Well, there are two kind of different. So erectile dysfunction is often a manifestation of a chronic medical problem, let's say diabetes, heart disease, high cholesterol, smoking. If someone's on opioids, all these things can cause erectile dysfunction. So for those kinds of issues, I think what you really need to do is address whatever chronic medical problems you may have to overall looking at your health that way, meaning avoiding excessive alcohol, not smoking, exercising regularly, watching your diet if you have a high cholesterol, making sure you address that, because the changes that are causing erectile dysfunction are kind of microvascular, but a reflection of sort of bigger pictures. Does that make sense? And then in terms of overall genitourinary health, I think it's very important to drink a lot of water and get a lot of exercise. And there's anecdotal speaking, if you bicycle a lot, maybe that's hard on your prostate. I've heard that. But there's ways to adjust bicycle seats and things like that in order to make sure that that's not a challenge. So I guess in general, that's kind of how I would look at that question or answer that question.
Very good. And Dr. Marsh, we might have time for this question. Can you just basically compare and contrast an internal or external approach to a prostate biopsy?
I don't know if there's only one, okay. So the most common approach is using an ultrasound probe up the rectum and biopsying the prostate through there. There's been a push to try and do a different approach transperineally through the skin to decrease the risk of infection associated with that biopsy, but that's been a little bit slow. It has kind of a high learning curve. So that will probably be the way of the future 5-10 years from now, but right now most of them are still done internally.
Thank you. Well, it looks as though we've covered most of our questions. I want to thank our panelists, Dr. Benjamin Marsh and Dr. John Wood, and our medical student volunteers, Riley Berg, Micah Christensen, and Alex Host. Please join me again next week for a program on lower extremity, knee, foot, and hip problems, when my panelists will be Dr. Billy Hogue, Dr. Christy Hultman, and Dr. Luke Widstrom. Thank you for watching. Good night.